Good afternoon. Thank you for joining us today for Facebook Live Q&A. I'm Dr. Joy Ballsbury, Assistant Professor of Epidemiology at Mayo Clinic. Today we are going to talk about uterine fibroids. We'll be taking questions throughout the broadcast, so make sure to post your questions in the comments section below. Joining me today is Dr. Shanon Laughlin-Tommaso, Associate Professor of Obstetrics and Gynecology. Dr. Shanon, please tell us a little bit about yourself and why you decided to do a career in women's health.
Sure. Well, thanks for having me. I'm excited to be here. I originally went into women's health because I thought I wanted to do pediatrics, but I realized I related a lot better to the moms. Mm-hmm. And especially, I really liked helping women be able to take control of their own health care. I did my obstetrics and gynecology rotation, and I love the joy and the chaos of obstetrics, but I really like the surgical aspect of gynecology. And then I specifically got into fibroids because I applied for a fellowship and I worked for the National Institute of Health. And I studied the risk factors and epidemiology of uterine fibroids, which is a benign disease but can affect a lot of women. Mm-hmm. And since then, I've been studying ever since.
Okay, thank you. So one of the things that we were going to talk about is what are the symptoms of uterine fibroids? Can you tell the audience a little bit about that today?
Sure. Uterine fibroids are benign tumors of the uterus, but they can be confusing. In ultrasound screening studies where they do an ultrasound on a lot of women, about 50% of women won't know they have fibroids or won't have symptoms of them. But in the other 50%, they can have symptoms, and sometimes it's severe. The number one symptom is heavy menstrual bleeding. Okay. And that's bleeding for more than 7 days a month, or bleeding where you're changing a pad or tampon every hour to 2 hours, bleeding through clothes, or bleeding severe enough to become anemic or have low blood counts. Some women require blood transfusions, so it can get pretty serious.
So how do women know that those symptoms are related directly to fibroids?
That can be pretty difficult to tell. The other kinds of symptoms, like bulk symptoms, which is where the fibroids get really large, are usually fairly vague. And so things like constipation could be caused by a lot of things, or bladder pressure, urinary frequency. Those kind of things can also be associated with other diseases. But what we do is we try to see if the size and location of the fibroids is appropriate to be causing your symptoms.
So can you tell us a little bit about the testing that women would need to find out if they have fibroids?
Mm-hmm. Usually the first test is just an ultrasound. So if you're describing symptoms and your doctor's suspicious of uterine fibroids, they would typically get an ultrasound first. And then what we do is we try to figure out whether or not the symptoms that you're describing are related to, as I said, the size and location of the fibroids. Mm-hmm. So if your fibroids are found just by chance alone and you don't have any symptoms, you may not require any further testing at all. But if you're having symptoms, I like to individualize the testing to those symptoms. So for instance, we're going to show a little graphic here of uterine fibroids. It's really important to know whether your fibroids are inside the uterine cavity. So what you can see on this graph are multiple different fibroids, some hanging off the top of the uterus, some just there as little circles inside the uterus, and one is hanging inside the cavity. Those fibroids that are inside the cavity can cause the heavy menstrual bleeding.
So what types of tests are usually done? You mentioned that I know that sometimes ultrasound is generally one of the first tests. Can you describe that process for our listeners and viewers today?
Mm-hmm, sure. Ultrasounds are usually done in radiology. They can sometimes be done in the office as well. And a typical ultrasound will use an ultrasound probe on the abdomen and look first at the overall view of the uterus and the ovaries and look at your fallopian tubes as best they can. But there's also usually a transvaginal portion, and this can be a little bit uncomfortable. It is a wand that is inserted inside the vagina, and it gives us a much better view, though, of the uterus. There's two other kinds of tests that we can look at specifically for fibroids inside the uterine cavity. And I have a couple more graphics because these can be a little bit more confusing.
Okay, great.
So the first one is the saline-infused sonogram. And what this shows is the ultrasound wand inside the vagina, but then a catheter going up into the uterine cavity. And through the catheter, we insert or we push in saline, and that really opens up the cavity. And then it can tell us if there's a fibroid hanging in the cavity like the picture you saw before. The second kind of test I have a separate graphic for, and that's called a hysteroscopy. And this is done more like getting a pap test where you have a speculum inserted in the vagina, and then we take a tiny little catheter a tiny little camera, and we insert it into the vagina and up into the uterine cavity. And this is something we do here in the office. Most women tolerate the procedure very well. They can take Tylenol or ibuprofen beforehand and then tolerate the procedure well, and they get to watch live to see if they have fibroids inside their cavity.
So how does a woman know which test she should have done?
Well, it's really important to talk to your doctor, and as I said, to individualize the testing for the symptoms that you're having.
Mm-hmm.
So if it's mostly heavy menstrual bleeding, you want to be having a couple tests, either the initial ultrasound, if that's clear enough that there's nothing in the cavity, you don't require the saline-infused sonogram or the hysteroscopy.
Mm-hmm.
You may need an endometrial biopsy, which is a test that takes a sample of the lining of the uterus and tests it for precancer or cancer.
Okay.
And that depends on age and other risk factors that you have. So you really need to be able to talk to your doctor about all of the things going on surrounding your bleeding.
So what happens if you or another physician notices that a woman has a uterine fibroid in her vaginal cavity, in the uterus cavity?
Yeah, if there's a fibroid in the uterine cavity, what we would do is we'd recommend a specific kind of surgery for that. So we like to remove those fibroids that are inside the cavity. Generally, women get a lot better. They have a reduction in their heavy menstrual bleeding. A lot of women will describe that kind of bleeding as gushing or passing clots, and that will decrease when you remove it. It also gives us a chance to use other kind of medical therapy for the fibroids once that fibroid is out of the cavity.
Okay. So one of the things that I know that comes up with a lot of women that have uterine fibroids is their quality of life as it relates to heavy menstrual bleeding. So what are some of the things that someone can do if they do have heavy menstrual bleeding while they're trying to wait for their treatment options?
Well, a lot of what women can do, you make a good point. Women miss work every month for this. Mm-hmm. Some women plan their travel around having to stay home. So it can be a big factor in quality of life. So sometimes we have found that things like physical activity and increasing your physical activity can be related to a reduction in bleeding. So lifestyle changes can help. Of course, loss of weight does help if you're overweight. And then the other thing is a good diet. So there's some evidence that plant-based diets or even vitamin D can affect the amount of bleeding and can affect uterine fibroids. Those have not been proven, though, in long-term trials, and that's why a lot of times we wind up going to medical therapy initially to treat the bleeding related to fibroids.
So what type of medical therapies are available to treat fibroids as well?
Yeah, there's a lot. Now, most of the therapies treat the bleeding associated to the fibroids, but don't necessarily treat the fibroids. But I'll talk about a couple treatments coming out on the horizon that really will help us in treating both the fibroids as well as the bleeding. But some of the options, there's two options that are non-hormonal, and you just take them during the bleeding cycle alone. One is called tranexamic acid, and the other is kind of like ibuprofen.
Okay.
And so those are ones that you just take during the cycle, and then after the bleeding is done, you can stop. You really only have to take it about 5 days a month. They'll reduce, which is a really nice option instead of having to go all month long. It will reduce your bleeding about 20 to 40%.
Okay, that's great.
Yeah. Then there's also birth control pills. So some women are using them anyway for contraception, but they do reduce bleeding about 30%, sometimes higher in other women. Of course, birth control pills are ones you have to take around the cycle, all month long. But they're a great option that provides contraception and bleeding control. And then the IUDs, and I have a graphic just to show you what an IUD looks like. And so this is an intrauterine device. There's several progestin-type devices. Things you might have heard of are the Mirena, the Kyleena, the Liletta. Those are all ones that have progesterone in them. And those seem to be very effective for heavy menstrual bleeding. People worry a lot about having an IUD in with having uterine fibroids. And there's some evidence that maybe the IUD would come out more frequently if you have fibroids. But if it works for you, it reduces bleeding about 70 to 90%.
Oh, wow. So that really is a good option for many women.
Yes, and it's a contraception too, so it works well for that. And most women tolerate it very well, so they will have a huge reduction in bleeding, usually have less anemia, and a lot of times their cramping gets a little bit better. They also don't have as many side effects usually as the birth control pills, but of course that's pretty individual to each patient.
Yeah, and it sounds like the options that you mentioned really relate directly to women that want to possibly maintain their fertility as well. I know that you mentioned that there's some new generation treatments that are coming out. Can you tell us a little bit about those next generation options?
Yeah. So one of them has been really trialed for a long time, and the long-term technical term are selective progesterone receptor modulators. And there's been a bunch that have come through, but the one that's currently approved in Europe and Canada and is going through trials here in the United States is called ulipristal acetate.
That's a long name.
That's a long name. But the what it does is basically it treats both the bleeding and the fibroids.
Okay.
So a lot of women go to very minimal bleeding. It's a huge reduction in bleeding, improvement of their anemia, but it also seems to shrink the fibroids.
Interesting.
Yeah, what they're doing is they're now studying to see if women can take it for, say, 12 weeks on and 12 weeks off, and so that it would be the first kind of long-term preventative medical therapy.
Mm-hmm.
Similar to that, there's another medication coming out, or actually I think there's a couple in trials right now.
Mm-hmm.
We have a similar medication right now. It's called Lupron or leuprolide acetate, and that's a shot. And what it does is it basically shuts down the ovarian function. So you basically go into a temporary menopause while you're on it. So, of course, a lot of women will have hot flashes and other symptoms with it. But these new medications are oral, so it's not a shot, and they seem to have less side effects. But those are going through trials right now in the United States as well. So we're anxiously awaiting a couple of things in the next few years, which really might help us treat women and preserve fertility, as you mentioned.
Okay, that's great. So one of the things that I know that might be curious in a question for our audience is the removal of fibroids. So what are some of the options for the removal of fibroids?
Well, myomectomy is the long term for removal of fibroids, and that's where we focus on removing the fibroids themselves but keeping the uterus intact. And myomectomy for a long time has been the gold standard for future fertility. And as I mentioned, the one way is hysteroscopic myomectomy. So we use a camera, we go in through the vagina and in through the cervix, and we reduce the fibroids using a device that goes straight through the camera. That means that there's no abdominal incisions. If your fibroid is large or not inside the uterine cavity, though, you may need what's called an abdominal myomectomy. And that can be done either laparoscopic with tiny incisions or open with a bigger incision. And again, that just means making an incision on the uterus, opening up the uterus over the fibroid, removing the fibroid, and putting the uterus back together. Now, there's some risks and benefits to doing the myomectomy, but it is the one kind of term for removal of fibroids.
Okay. Can you talk a little bit about some of the other surgical treatments as well, like hysterectomy and things like that also?
Sure. So hysterectomy means removal of the whole uterus. It doesn't mean removal of the ovaries, which is good. A lot of our patients with fibroids are very young, and if they decide to go with hysterectomy, then they don't necessarily want their ovaries out. There's several ways to do hysterectomy. The leading way to do it is a vaginal hysterectomy, so to remove it through the vagina with no incisions on the abdomen. And then there's a laparoscopic or an open one, similar to how I described with the myomectomy. But that's the option, that's the only option that we can guarantee you don't have periods afterwards and you don't have fibroids. But for a lot of women, that's not very acceptable. So there's 3 other different treatments that shrink fibroids, but don't necessarily, or they don't remove the fibroids from the uterus. The first one is the focused ultrasound ablation, and I do have a graphic for that too, so we can show that. Basically, this is an MRI-based procedure. So the woman lies inside an MRI machine and lies over a specialized ultrasound machine. And the ultrasound brings those waves together, and it heats up the tissue and treats it by shrinking the fibroids. Now, the key is that it decreases the blood flow to the fibroids, and it will make them less active. So women get a lot of symptom relief, including bleeding and cramping and pelvic pressure. But the fibroids are still in the uterus. Similar to this, there's a uterine artery embolization. And what uterine artery embolization is where we go in, make a little puncture in the groin, and go through the blood vessels around to the uterus. And we treat the fibroids by decreasing the blood flow to the fibroids again. So again, the fibroids become less active, and the symptoms are really alleviated. Now, the last one is the newest one on the market, and it's called a laparoscopic radiofrequency ablation. And that is a laparoscopic procedure, so it is surgery. So it kind of carries the same risks as other laparoscopic procedures. And what it does is it uses a little device that you insert right into the fibroid to, again, heat up that tissue and decrease the fibroid size. So in all of these, you will still technically have your fibroids, but they tend to be less symptomatic, less active. And for some women, that really works well. What we try to do is get patients to menopause, where fibroids are going to shrink and be less symptomatic overall. And those kind of treatments work really well for some women who are closer to menopause.
So what are some of the risks of these procedures that our audience needs to be aware of?
So anything that has surgery, including all of the myomectomy and the hysterectomy and even the laparoscopic procedure that I mentioned, there are risks because we do go into the abdominal cavity. So there's risk of bleeding, infection, as well as injury to other organs around the uterus. So you're thinking bowel and the bladder. Generally, those risks are pretty low, but they can occur, and of course they can be serious at some times. The procedures for focused ultrasound and uterine artery embolization that have very minimal incisions and are not surgical procedures tend to have very little complications. The things that we worry about is with the focused ultrasound is you could get a little bit of nerve injury. Usually that's self-limiting and it goes away. We protect against blood clots in the legs and the lungs during the procedure because those are always things we worry about in surgical and non-surgical procedures. And similar for the UAE or uterine artery embolization, we sometimes worry about pain initially and we keep patients in the hospital overnight. But again, these are pretty rare risks and are overall really safe procedures.
Okay. I know for a hysterectomy, that's really a long-term option where the uterus is removed. But for the other 3 treatment options, medical, surgical treatment options, how long do those treatments tend to last?
Yeah, that's a good question. So if we think about the medical therapies, it's really how long the patients can tolerate it. So something like an IUD will last 5 years. But the tranexamic acid, birth control pills, that's really more self-directed care. And so it's as much as the patients can tolerate. Some patients do great and they can stay on birth control pills or even the tranexamic acid for long periods of time. But a lot of women wind up going to a bigger treatment option from medical therapy. We're still working out how do we predict who will do really well with medical therapy and who should go on to more surgical procedures. For the focused ultrasound and uterine artery embolization, it's one of the outcomes we look at is what we call reintervention rate. So how many people are going to go on to future therapies? And that's true for myomectomy too. And that can range from anywhere from 11% to 40%. And it depends on how long you follow the women, but it also depends on how young they are when they start. So women who get treated at age 25 still have about 25 years until menopause. And therefore, they may need another treatment if they get their initial one at age 25.
Interesting. So I think now we'll see if we have any questions from the audience. Actually, I want to, some questions from the audience. And so how do you go about finding the right physician for fibroid treatment? This is one of our audience questions.
Oh, well, that's a good question. I think it's really important to first find out if you have fibroids and you want to go and visit a gynecologist, have an exam and have the ultrasound. And if you're only being offered one option for fibroids, I think that's time to start questioning whether there's anywhere else you could go. So the problem with some of these treatments is they're not available everywhere. Focused ultrasound ablation, there's only a few places in the country that has it, Mayo Clinic being one of them. UAE or uterine artery embolization is more fairly universal across the U.S. But the laparoscopic radiofrequency ablation is also pretty minimal right now.
Okay, is Mayo one of the places that's offering that procedure?
Not currently, but we hope to be soon.
Okay.
And so for that, I mean, if you're only being offered hysterectomy, then you may want to ask for other options.
Okay. Another question from our audience is, do uterine fibroids cause abdominal bloating or enlargement of the waistline?
Yes, they can. So fibroids are really unique because they're benign, but they can grow to a really large size. And so some women will present and their fibroid will be all the way up to their belly button already. And so for that, you can certainly see that women will start describing that they've gone up in pant size in the last couple of years, or they're having a lot of bloating, and they usually indicate that above the fibroid. So the fibroid has displaced all the bowel and kind of is pushing up and causing a lot of bloating.
Oh, wow. So we probably have a couple other questions. So do fibroids shrink as you age?
So there's only been one study that's really looked at fibroid growth and looked at that question. Now, most people have seen clinically that after menopause, fibroids do shrink. So once you go through menopause, that's true. They seem to get smaller. They get what we call calcified, so they get less active, and they're usually asymptomatic. In fact, we worry about women after menopause who think they have symptoms of fibroids because we start worrying about cancer or precancer in that situation. But before menopause, there's only one study, and what it found was that they continue to grow all the way until menopause, but that there's a difference by race. And so white women had a decrease in the fibroid growth rate down to about 2% every 6 months, versus African American women, who we know are already have a larger burden of disease. They get fibroids younger and they get more severe disease, and their fibroids tended to grow all the way up until menopause at about the same rate, which tended to be about 9% every 6 months.
So this is one of our last questions, but for our audience, please feel free to ask others. So the question is it okay to just leave them if you're in your 40s and not planning on having any more children?
Absolutely. So we do recommend that, again, you talk to your doctor about what symptoms you're having. About 80% of women will have fibroids by the time they reach age 50.
Wow.
Yeah, so it's a very common disease, and we don't want all of those women having to get their uterus out before age 50. If you're severely symptomatic, or there's concern about the amount of bleeding you're having, or the fibroids seem abnormal, then yes, you could wind up getting your uterus out for those reasons. But for the vast majority of women, if they're not symptomatic or their symptoms can be controlled in other ways, it is not required to get your uterus removed.
Okay. Dr. Shanon, thank you so much for speaking with me today.
Sure.
And to our audience, thank you for joining us today for our discussion about uterine fibroids. If you didn't get a chance to answer your question, we will try to do so after the broadcast. Thank you, and have a great and wonderful rest of this week. Bye-bye.